Thanks, Anthony. So my name is Max Conway. I'm affiliated with Sydney University's Safe Side Institute at Sydney Eye Hospital and also with the St Vincent's Kinghorn Cancer Centre. I'd just like to start by saying this forum, the AOMA, is quite a unique forum. I think the meeting has been really excellent. Yesterday it was outstanding, and today outstanding again, and particularly all the speakers this morning, but especially the four last speakers, Ian, Jess, Jody and Glenn, because I think those four speakers have really encapsulated some of the main priorities we need to be looking at as a forum and as a group. I think Jody beautifully outlined the need for new treatments, and I think we're all well aware of that. We need to have better treatments for the eye. We need to have better treatments or effective treatments for metastatic disease. But then Ian and Jess and Glenn have raised some very important issues. Firstly, about early detection, and I'm going to talk about that more in this talk. And I think Glenn and Ian also, and Jess, made the very good point that we need to look at this support aspects for patients with ocular melanoma, because that is something that falls through the cracks a little bit in our health system. With a rare disease, patients are often living outside major centres, and I think that's something we could work together for you to help us, to help you, to have better support and know where to go for support with the diagnosis of ocular melanoma. So that's just a preliminary observation. So this image here is fairly familiar to us these days in eye health circles. It's an ultra-wide field retinal digital photograph. It gives you a beautiful panoramic view of the retina. There's the macula, the optic nerve, the blood vessels coming out. And these sort of pictures can be taken without the dilating drops. So they're really amazing. We see with the older versions of retinal photography, you can see about 15% of the retina, but with these newer amazing cameras, you can see up to 82% or around 200 degrees of the back of the eye. It is important to note, however, that with this technology, there is a little part of the retina here called the peripheral retina, and a part here called the ciliary body, where melanoma can occur, that does not appear in these photographs. So this is the kind of equipment that you're probably all familiar with. It's widespread in optometric practices, in eye hospitals and eye departments and in ophthalmologist offices. And even nowadays you can download apps to an iPhone, smartphones, and anybody virtually who can use an iPhone, point it in the right direction and take a photograph is able to take retinal images. So this has obvious advantages. It's relatively quick and easy to perform. It's becoming easier and easier to access and cheaper. Compared to indirect ophthalmoscopy, which is the traditional way of examining the fundus, there's relatively little skill required. It can be performed without dilating drops, and therefore it's a very useful screening tool to a degree. Anecdotally, these modalities are picking up nevi and small melanomas. And this is important, and I'll come back to this message. This is important because early detection and treatment of small melanomas is currently one of the main opportunities we have to improve survival in this disease. So here we see one of these photographs. There's a little nevus there, there's a nevus there. Typical sort of patient, I see around about 4 or 5 new patients per week who've been sent to me by a general ophthalmologist or an optometrist, and they've found something on one of these photographs. So this is the traditional way we examine the back of the eye. It's called indirect ophthalmoscopy. And to do this, you need a well-dilated pupil, and you need quite a lot of training and practice. It takes a number of weeks and even a few months of constant practice to be good at doing this. There are also other ways of examining the entire retina with certain contact lenses you can put on the eye. So although the new technologies give wide beautiful panoramic views, they do not fully visualise the far periphery and ciliary body. Currently, with the current technology, you know. It is possible to miss even quite large lesions in the far periphery and in the ciliary body, and I've certainly seen patients who've had lesions missed because it just wasn't in the photograph. There's also the other issue, who I think, I can't remember who it was, I think it might have been Jody referred to, that sometimes these photos detect nevi, but then somebody's interested in something else, the macula, the optic nerve, and there's kind of a disconnect between the photo and the brain, in a sense. So that's a question of education, awareness, and so forth. Thus, although a useful screening and monitoring tool, indirect ophthalmoscopy through a well-dilated pupil in experienced hands is required for diagnostic purposes, in my view. So in other words, if you have symptoms like flashes or a peripheral shadow, really you need a proper dilated examination. Now, everything in life has challenges and dilemmas, and so does ultra-wide field photography. I've mentioned some of the shortcomings there. We're seeing more nevi, and about 7% of the general population have an eye nevus. But very few of these will ever develop melanoma. Overall, it's a risk of 1 in many thousand. So most of these people will just have a benign condition that never causes any problem with their sight and no risk to life. So how will we best allocate scarce resources to manage an increase in detection of nevi? And this is a public health issue, it's an education issue, and I don't have the answers here today, but it's something we should discuss as a group and think about how we deal with this and how we better screen patients. So one of the concepts in terms of trying to manage, if we're picking up more nevi, how do we make the best use of the health dollar to ultimately reduce or improve the outcomes, detect uveal melanomas and improve the outcomes? And one is the concept of risk stratification. So if we look at the risk factors, susceptibility factors for uveal melanoma, these include fair skin, light colour, inability to tan, certain unusual nevi such as the ocular or oculodermal melanocytosis, the more common nevi of the iris and the choroidal nevus, a family history of cutaneous and uveal melanoma, and the BRCA-associated protein, better known as BAP1, gene mutation. So we can't do much about our skin colour, our eye colour, our tanning ability, or our family history. At the moment we can't do much about BAP1, although it's a very interesting area where maybe some new treatments will emerge. And there's also the suggestion that there's some screening possibilities there. But the main area where we can make a difference today is in relation to the nevi. This is because most uveal melanomas arise from a pre-existing nevus. The presence of a nevus is currently the main actionable target in this disease. So this is a study that's been referred to before, the Collaborative Ocular Melanoma Study. This was a very large, long-term, multi-centre, series of randomised controlled trials. They ended up looking at 1,300 patients by the end of this study in 1998. And this study clearly showed, as Ian mentioned and Jody, that if you have your melanoma diagnosed and treated when it's small, you have much better survival than if you have it diagnosed when it's larger. And in fact, if it's picked up when it's at a small stage, you have an over 80% 5-year survival. And these figures are still more or less the same today. So if the melanoma was diagnosed and treated when it was small, survival is likely to be better and metastases less common. If we can find and treat small melanomas and the lesions that precede them, we should be able to prevent metastatic disease. With modern screening tools, we should now theoretically be able to achieve this, in my view. Finding and treating small melanomas. As I've mentioned, there's a trend to be more proactive in treating the earlier lesions and finding the small melanomas. Although it's not proven, knowing from the natural history of uveal melanoma, it's reasonable to assume that finding and treating them will reduce deaths from metastatic uveal melanoma. The algorithm for characterising the high-risk lesion, that is the lesion that sort of immediately precedes the onset of melanoma, is not perfect. But I think we have enough information, at least to make a start in terms of making progress in developing risk stratification. And of course, it's always a balance between reducing risk and the morbidity of any treatment that's proposed. So what we can do now, perhaps, first of all, education is very important, but it's more than just education. To educate, we need to have what I've called a baseline nevus assessment. We need to know about the nevus. You know, it's not good enough to say, oh, I've got an eye nevus. We need to have more information. Is it a low-risk nevus? Is it a higher-risk nevus? Is it a very high risk? And then once we've made an evaluation of that, we need to educate the patient about their level of risk, and we need to develop an individualised nevus surveillance program based on the estimated risk. And this is not anything revolutionary. Dermatologists are doing it all the time with skin moles. Of course, they have the luxury that they can just do a biopsy very easily. At the back of the eye, that's not such an easy proposition, so we need other ways of doing this surveillance. Another area which has already been mentioned is raising community awareness about the significance of ocular nevi. Many patients I have sit in front of me and you talk about ocular nevi and they're quite surprised to hear, to even learn that such things exist. So I think overall there's a relatively low level of awareness in the community about ocular nevi, their potential significance. And of course, an important part of this equation is educating colleagues such as optometrists, orthoptists, GPs about the need for nevus assessment and possible surveillance. Another emerging area is the possibility of screening high-risk patients and families with germline gene mutations. I'll talk a little more about that at the end. So the baseline evaluation and surveillance of nevi, in my view, all patients with uveal nevi warrant a baseline oncology evaluation or nevus evaluation to estimate the risk and stratify to an appropriate personalised surveillance program. And of course, this requires training. We need to train people how to do this. They need to be properly educated and trained. It's not a sort of Dr. Google thing. So baseline is this is what I do when I see a patient with a nevus. I take a comprehensive clinical history. Do they have symptoms? Do they have they had any significant conditions themselves in the past, like skin melanoma? Is there a family history of uveal skin melanoma? I take a high-quality retinal photograph to document all the features of the lesion. I do ultrasound, where I do measurements, and I look at the characteristics on the ultrasound. In all patients, I do autofluorescence, which looks at accumulation of a pigment that's associated with nevus growth. And in some patients, I do these other tests, OCT, fluorescein angiogram. Basically, once you've done the history, the family history, the photograph, plus or minus the ultrasound, you can broadly categorise all these nevi into low, medium or high risk. Low risk lesions have a very low chance of turning into melanoma, 1 in many thousands, if you have 1 or no risk factors. And usually these patients, all I recommend, I talk to them, counsel them about the presence of a nevus. I suggest they have a checkup every year or two and have a high quality photograph. And that often can be done by an optometrist, or I'm happy to see them as well, or in an eye department in a hospital. Then if we have greater than 1 risk factor, there's a higher level of risk, still quite low. I often offer to see these patients. I might be seeing them every 6 to 12 months. I'm doing most of these tests. And then with the high risk nevi that have 3 or more risk factors, some of these, or even maybe more than 50% these days, I'm offering treatment to, but others I am watching for various reasons. I'm usually doing all these investigations on these patients, and I'm seeing them every 3 to 6 months. So just to mention 2 other things, If there's a documented growth, that is, the lesion has actually been documented to grow, or there are symptoms referable to the lesion, these are sort of outliers, they're sort of red flags, and they in general don't denote a high-risk lesion, they denote melanoma, so that automatically puts the lesion in a high-risk category. They don't need 3 risk factors if they have documented growth or symptoms referable to the lesion. Here's another cautionary sort of tale. This is published by Carol Shields, who Jodie mentioned, and we see here the entity of a diffuse or flat choroidal lesion. They can appear very bland, they can just look like a nevus, but here Carol reports a lesion that grew quite significantly in only 3 months. So I think it's important that we can underestimate the risk in these sort of lesions, and I think it's important for newly diagnosed choroidal nevi to be re-evaluated in 3 to 6 months to exclude early growth tendency. So just to move on to the second half of the talk, which I'm running over time, this will be very quick, it's not a half, it's about 2%. The Batline gene mutation. So this is the BAP1 gene, which is an important driver in uveal melanoma, which most of us have heard about. This occurs within the sort of less favourable prognosis uveal melanomas. But there's a minority of patients in whom the mutation can occur in the germline, the egg and the sperm cell. And so these patients can inherit uveal melanoma. It can cause what's known as a cancer predisposition syndrome. So you have one mutation in the germ cell, you then only need a second mutation in the tissue giving rise to the tumour, and you have a tumour. So this is one series that was reported of 87 families, and patients with this germline mutation have a high risk of development of various cancers. There's uveal melanoma in 28%, there's pleural and peritoneal mesothelioma, renal cell carcinoma, and cutaneous melanoma. Now, we don't actually know what the prevalence of this mutation in the general population is. And the point about the BAP1 mutation also for uveal melanoma is that the prognosis is somewhat different for uveal melanoma. The melanoma tends to be more aggressive, larger tumour size, increased ciliary body involvement, metastatic potential is higher. We published a study last year with my colleagues at the Melanoma Institute looking at discussing or analysing the dilemmas over BAP1 surveillance. While screening may lead to earlier cancer diagnosis, there are dilemmas in terms of screening patients, and dermatologists, pathologists and ophthalmologists are at the forefront of identifying these the possible patients who might be candidates for screening. This is just in passing showing you that one of the earliest manifestations of this syndrome is the so-called bopOMA. It occurs in 70 to 75% of patients with the mutation. It's sort of an unusual little fleshy pink raised lesion. It occurs in the 2nd to 3rd decade of life, and it has characteristic histological features here that the pathologist can recognise. The BAP1 syndrome is associated with some other cancers as well, less commonly. But as I mentioned, there are unknowns. The prevalence of the germline BAP1 mutation in the general population is not elucidated. There's limited data on cancer risks for unaffected carriers. Genotype-phenotype correlation, that means sort of matching a particular mutation with a particular tumour outcome or particular disease outcome has not been fully worked out. And there's lack of proven benefit for surveillance. What would an appropriate surveillance plan entail? Would it lead to earlier stage at diagnosis? Would it reduce mortality? We don't know the answers to these questions. There are potential harms to screening. There can be morbidity arising from, say, biopsies, invasive investigations, risk of genetic discrimination, employment and insurance implications, lack of public funding for imaging costs in rare inherited cancer syndromes, the possible net gap in clinical experience to coordinate surveillance, psychological burden of intense surveillance. But having said all that, this condition exists and we need to be aware of it, and the test for the gene exists, so we need to have some idea of how to manage these patients. And for the eye at least, the screening is not difficult, surveillance is not difficult. We concluded that it's reasonable just to do yearly review by an ophthalmologist specialising in uveal melanoma, starting at the age of 16, and twice yearly visits from 30 years old. Examination consists simply of direct and indirect ophthalmoscopy, high quality fundus photography, and ophthalmic ultrasound. So conclusions: BAP1 mutation in cancer syndrome. The evidence suggests that BAP1 germline mutant carriers are predisposed to cancer, but the prevalence and risk are unknown. Adequate frameworks to screen patients need to be put in place. There are uncertainties and dilemmas I've mentioned. Advances in genomic understanding are exciting in terms of developing new treatments, but there are significant ethical, clinical, legal and moral risks in terms of screening and doing genetic tests. These recommendations in that paper were a starting point, and if you are thinking about having this test, I'd suggest that you look into it and you actually go and get some formal genetic counselling about the pros and cons of having a test, what would be involved in terms of if the result was positive, and really looking at the risk-benefit ratio. I'd just like to thank my collaborators at the Kinghorn that I work closely with, Anthony Joshua, Michael Giblin, Svetlana, Candice, my orthoptist. She's amazing in picking up nevi. She sees all my patients and she picks up many, many small nevi just in the routine initial evaluation. My patients and my collaborators at the MIA, with whom I did the BAP1 screening work, and in particular to Phoebe Starr, who's actually not on the list, who was the lead author in that paper, and who kindly lent me her slides for the second half of this talk. So thank you very much for your attention. I'll stop there.